Good morning, everyone. Thank you, Chairperson, for the kind introduction. At the outset, I thank Dr. Kumarvel sir and team for giving me this opportunity. So the topic given to me is when and how to de-intensify diabetes. So again, this concept is relatively new. 2 decades back, the guideline says intensify till HbA1c less than 7%. After that, we had a lot of landmark trials like ACCORD, VADT, Advance, where they showed intensive treatment in selected patients leads to increased mortality. Then we started talking about individualized targets, etc. So the concept is right intensity for right people. So now even this concept has been integrated in many guidelines also. So what I am going to discuss is what is the case for de-intensification, why should we do de-intensification, how to identify the right patient, and what should be the target for these patients, and how should we strategy, what are our strategies to de-intensify, and finally about the algorithms and what are the barriers to the de-intensification. So what are the cases for de-intensification? Again, if we see epidemiologically, the people are living more. So if we see prevalence of diabetes in more than 65 years of age is almost 30%. And even type 1 diabetes people with very effective management, they are living into the elderly population also. And elderly population itself, we have different classes. So it's not like one treatment fits to all. So we have healthy elderly population, we have elderly population with various geriatric syndromes, and we have elderly population with various cardiovascular risk factors also. So we have to again divide the treatment, because in healthy population we can have a normal targets. In geriatric patients and the geriatric syndromes and cardiovascular classes, we have to again modify our treatment. So over treatment is very common, harmful and under recognized. Why? Because most of the times whatever guidelines we have, all these guidelines says the targets are based on the studies from the younger, healthier individuals. Usually all the studies would have excluded the frail patients, elderly patients, etc. So severe hypoglycemia can increase illness, death and cognitive decline, and multiple pharmacy, polypharmacy also leads to low adherence and life quality. And most of the times, as Dr. Vijay Bhaskar Reddy was discussing, hypoglycemic events are often underreported in our patients. Many times they don't do investigation, they have asymptomatic hypoglycemia, so many times underreported. And as I told, there is a lot of huge evidence gap. Frail and elderly patients are excluded from almost all the trials, so we don't have much data. So this is called paradox. So we are again doing our best to prevent long-term micro and macrovascular complication. But again, in selected population, if you are just following this, it can do a lot of harms. So de-intensification is not a therapeutic negligism. That is, we are not denying treatment to the elderly population, but it's a precision medicine applied to risk-benefit calibration. So we should not do more harm rather than doing any benefit. So now the concept is changing. Before we used to have fixed population level HbA1c goals. So intensify treatment irrespective of the patient complexity or the life expectancy. But now it's individualized goal. We calibrate we keep the target according to the frailty, functional status, comorbidity, etc. And also therapy intensification is justified based on the patient's life expectancy. We just don't start SGLT2 inhibitor, GLP-1 receptor analogs in people with life expectancy of 1 or 2 years. Okay. So again, it has to be very, very precise. So who is the right patient? So again, as I told, there's a lot of heterogeneity in older adults. 78-year-old marathon runner and 80-year-old nursing home resident, we can't give the same treatment. Oh, you are 78 years, you are also 78 years, you have to we can't de-intensify. We have to classify the patient, fit patient, healthy, elderly, independent, minimal comorbidity, near normal life expectancy, keep standard targets. Intermediate, multiple chronic conditions like urinary incontinence, falls or sarcopenia, mild functional limitation, relax the targets. Dependent or frail patients, again, two things are important. Avoid hypoglycemia, avoid hyperglycemia related symptoms. So be gentle, don't be very aggressive. Again, same time, not all frailty patients points to the same clinical decision. We have 2 types of frailty, sarcopenic, obese phenotype, where there is a preserved or increased BMI, visceral adiposity, increased insulin resistance, increased elevated cardiovascular risk. In this patient, it's justified to give molecules like SGLT2 inhibitor, GLP-1 receptor agonist, because the patient is going to get benefited. The same time, if the patient is anorexic, malnourished, low BMI, near normal HbA1c, risk of hypoglycemia, this is a strong candidate for de-intensification. So again, we have to see metabolic phenotype only. Also, it's not only the age and other things. We have to see metabolic phenotype and characterize the patient accordingly. select the patient, whether we are justified in doing the de-intensification. Next is, the question is, will this patient live long enough to experience the benefit of the therapy I am going to prescribe? Because whatever data we have seen, we have the data from UKBDS. If you treat the patient intensively for 7 to 10 years, we are going to prevent the microvascular complication. Most of these SGLT2 inhibitor, GLP-1 receptor analogs, if you give for 2 to 3 years, we are going to have macrovascular benefit. If the life expectancy is less than this, obviously it's not worth giving these molecules. There is no point in giving this SGLT2 inhibitor and GLP-1 receptor analogs, etc. It's better to de-intensify. So if the answer is no for this question, will the patient live long enough to experience the benefit? It's justified to do the de-intensification. Now we have tools also. There's a, I came to know when I was reading, there's a tool called LEAD tool, life expectancy estimator for older patients in diabetes. So we can use that tool to see the what is the life expectancy, and we can take a decision also. And also, what are the clinical triggers for de-intensification? Patient comes to the OPD. So if the patient complains of anything, any of this, then we should have at the back of the mind, we should decide this patient needs de-intensification. Any hospitalization, it's better in elderly population. It's a clinical trigger for de-intensification. Recurrent hypoglycemia, weight loss, frailty, functional decline, cognitive decline, patients on polypharmacy, and limited life expectancy. These are the clinical triggers for de-intensification. So finally, whatever I discussed, again, proactive identification is very, very important in elderly population rather than reactive management. So in our clinical practice, if we come across these candidates, it's better to think about de-intensification. Age more than 75 with multiple comorbidities, with at least more than 3 chronic conditions, with near normal HbA1c, or regardless of HbA1c, think about de-intensification. Patients on insulin with near normal HbA1c, again think about de-intensification. Patient on sulfonylurea plus any hypoglycemic events, don't think about this one. Just stop the sulfonylurea and convert to the standard drugs. Functional decline or new frailty, again think about de-intensification. These 4 phenotypes in our clinical practice we should be able to pick up so that we can prevent patient from developing some complications. So what next? So we have decided we are going to do de-intensification. So again, this is a 4M framework. So AD has taken it from the another guidelines, that is age-friendly health system. So 4 M's, that is what matters most. So discuss goals and expectation, see the symptoms, disease burden, the social support, life expectancy, etc. Medications, what are the medications they are on, risk of hypoglycemia, their affordability, polypharmacy, again social support. Mentation, whether they will be able to self-administrate medication, self-management, and their anxiety, depression status, and coping skills, whether they can adapt to the diabetes, newer technologies, etc. Mobility, functional complications, foot complication, functional ability, sarcopenia, gait imbalance, their vision status, hearing impairment, all those things has to be considered again before starting the planning for de-intensification. And always also screen for geriatric syndromes. There are a lot of geriatric syndromes. There are a lot of tools. Again, I know it's very difficult to do in our clinical practice. Again, simple questions we can ask, changes in the memory, feeling down or hopeless or depressed, any fall in the last 1 year, unusual fatigueness, difficult walking across the room, taking more medications, and we also ask about the urinary incontinence. So again, common geriatric syndromes we should ask. If there are any new developments, again, we have to think about de-intensification. What about the glycemic targets? Again, Dr. Vijay Bhaskar Reddy was discussing about this. So again, I talked about different phenotypes, healthy, intermediate, and poor functional and mental status. So in healthy patients, we can have this HbA1c target of 7 to 7.5. The TIR is same, more than 70%, TBR is less than 4%, and fasting target is similar to the general population, 80 to 130. But in intermediate patients, relax the targets, keep the HbA1c less than 8, and TIR 70 to 180, more than 50% is enough. But the most important thing is time below range. It should be less than 1%, not the standard 5%. And relax the fasting target also 90 to 150. In vulnerable patients, again, important thing is don't rely on HbA1c. We are not going to achieve anything by achieving the HbA1c of 7, 8 or 9. The main thing is avoid hyperglycemia. At the same time, the patient should not have hyperglycemic symptoms also. So it's better to keep it around below 180. So again, we don't have standard cutoff for the CGM. Again, time below range should be as low as possible. So fasting can be up to 180 and bedtime glucose can be up to 200. It's basically because most of the times the patient will develop symptoms when the blood glucose is more than 180. That's why they are advising to keep it less than 180. So how to implement? So again, important thing is start with the highest term and lowest benefit. So patients who are already on multiple medication, if the patient is on insulin and on sulfonylurea, de-intensify first insulin and sulfonylurea. Insulin, how to de-intensify, I will discuss in the next slide. And sulfonylurea, highest hypoglycemic burden, weight gain and lot of side effects. So first drug to be de-prescribed is sulfonylurea. Meglitinates, thiazolidinate, that's a moderate risk profile. Based on the clinical settings and phenotype, we have to take a call. And the molecules like SGLT2 inhibitors, GLP-1 receptor analogs, metformin, DP4 inhibitor, low hypoglycemia risk, we have cardiovascular and renal benefits. So it's justified to continue this molecule. So coming to insulin, so if the patient is on premix insulin, if you want to de-intensify, convert to 70% of the total premix dose as a basal insulin. So for example, if the patient is on total 20 units of premix insulin, change to 14 units as a basal insulin. If the patient is on only basal insulin, change timing from bedtime to morning. If the fasting glucose target of 90 to 150, continue the same dose. If the values are persistently high, you can increase by 2 units. If the values they are having hypoglycemia less than 80 multiple times, decrease the dose by 2 units. And the most important thing is if the patient is on prandial insulin, if the patient is developing recurrent hypoglycemia, the first thing to do is to reduce the dose of prandial or stop the prandial insulin. If the prandial insulin dose per dose is before meals is more than 10 units, decrease by 50% and add non-insulin agents. The safest thing is like metformin or DP4 inhibitor. If the prandial insulin dose is less than 10 units per dose, we can directly stop the therapy with prandial insulin and add molecules like DP4 inhibitor also. So sulfonylurea, as I told, highest priority for non-insulin de-prescribing targets because hypoglycemia risk is more, weight gain is more, and data are evolving that sulfonylurea induced hypoglycemia can accelerate the cognitive decline. So definitely sulfonylurea should be stopped if the patient is developing hypoglycemia. So discontinue directly, no taper required if HbA1c is at or below target. And glibenclamide, most of the guidelines are recommending avoid in all patients more than 65 years. Metformin and DP4 inhibitor are safe drugs. So metformin, various favorable profiles are there. So weight neutral, low cost, potential longevity, and even EGFR up to 30 we can use. So unless the patient is anorexic and GI intolerance, it's always safe to continue the metformin. DP4 inhibitor, it's like a fill and forget kind of drugs. So a lot of benefits, weight neutral, hypoglycemia, no hypoglycemia, and cardiovascular neutral. So it can act as a bridge therapy also. If you are going to stop the insulin, prandial insulin, or stop the sulfonylurea, very well we can start the patient on DP4 inhibitors. SGLT2 inhibitor and GLP-1 receptor analogs do not de-prescribe without specific clinical justification because this molecule has cardiorenal benefit, low intrinsic hypoglycemic profile. So ideal drug. So when de-intensification is appropriate, so GLP-1 receptor analogs, again, if the patient is anorexic, malnourished, and if the patient has, again, due to other comorbidities, its intake is poor, then probably we can prescribe GLP-1 receptor analogs. SGLT2 inhibitors, EGFR less than 20, recurrent UTI, or the patient or caretakers preferred after shared decision making, if they don't want the weight loss happening, whatever is happening with this molecule, then we can de-prescribe. So in fit or sarcopenic obese frail patient with established CVD or CKD risk factors, continuation of SGLT2 inhibitor and GLP-1 receptor analogs is the preferred strategy. So we have to, again, it's very important to stratify the patients, whether it's a sarcopenic obesity or malnourished obese frail patients. So this is a 4S algorithm. Again, it's recently published in the ADA guidelines. So 4S is 4 steps. Step 1 is investigate red flags based on the medical history, their mental domain, social domain, and the functional domain. If any red flags are there, then we have to decide the patient is eligible for de-intensification. Step 2 is re-evaluate the glycemic goals through shared decision making. Again, very, very important. We have to, again, involve the partners, the patient and the caretaker also in the decision making. Otherwise, they will think we are just let off the glycemic control going out of control. So they will think we are not giving proper treatment. So involve them also in decision making. Step 3 is de-intensify or simplify or modify the dietary regimen. Step 4 is reassess. After 2 weeks or 2 months, re-evaluate whether whatever you are doing is correct or not, so that patient doesn't go into hyperglycemia also. That's again very important. Coming to the technology, CGM is the single most powerful tool for safe de-intensification. Already Vijay Bhaskar Reddy discussed much about it. So what is the advantage compared to the SMBGs? Many times asymptomatic nocturnal hypoglycemia we pick up, postprandial excursion we pick up, and glycemic variability we will know from the CGMS, and time below range. That's very important because in these patients, rather than time in range, we are more concerned about the time below range. So CGM metrics that support de-intensification are TBR, time below range more than 4%, time in range more than 70% in elderly population, and glycemic management index less than 7.5%, then we can very well proceed with de-intensification. Just I'll finish my talk with three cases. So the first case is 78-year-old male, say HbA1c of 6.2, he is on basal bolus insulin. The symptoms are recurrent hypoglycemia, increased fear of hypoglycemia. He has mild cognitive impairment, CKD stage 3A, hypertension, and clinical frailty score is 5, so mildly frail. So what should we do in this patient? The first thing, elderly patient, HbA1c of 6.2, basal bolus, and recurrent hypoglycemia. Stop the prandial insulin, because very well under control. In this patient, the HbA1c target of 8% is very well enough. So discontinue the prandial insulin, reduce the basal insulin by 20%, and revise the HbA1c target to 8%. Probably we can put the patient on CGM and monitor this one. And as a bridge therapy, we can add DP4 inhibitor if the patient is having the hyperglycemia. The HbA1c goes more than 8%. So this is a classical over treatment in the elderly population, so we should change the treatment. Second patient, 83-year-old, HbA1c 6.5, BMI of 8.2, he is on sulfonylurea, glipizide 5 mg BD, and empagliflozin 10 mg. 6 kg unintentional weight loss over 4 months, 1 episode of dizziness or pre-syncope. He is also having heart failure with preserved ejection fraction, CKD stage 3B. Moderate frailty. So what should we do? First thing is stop sulfonylurea, very important. Whether we should continue EMPA in this group or not. It's better to discuss. Again, it's very dicey situation. So benefit of SGLT2 inhibitor in FF versus the volume depletion and also the weight loss. So here we have to take a critical judgment. So better to stop the empagliflozin also. In this patient, nutritional rehabilitation should be given preference over the glycemic management. So once that is taken care, then we can add the other medications as assignment required. Third patient, 76-year-old, HbA1c 8.2, BMI 32, metformin plus sitagliptin, established ACVAD, CKD stage 2, mild frailty. So what should we do? This patient requires intensification, not de-intensification, because obese, HbA1c of 8.2, already established cardiovascular risk factor. This patient is again indication for SGLT2 inhibitor and GLP-1 receptor analogs. Probably we can stop sitagliptin and add GLP-1 receptor and SGLT2 inhibitor. So not elderly patient means it's only de-intensification. We have to make clinical judgment whether intensification or de-intensification is required. Coming to various barriers, again clinical inertia, because again patient comes to us for good glycemic control. So they expect the HbA1c to less than 7%, 6.5%. Again, it's in the mind. So that's very, that inhibits us also from de-escalation, fear of hyperglycemia, and guideline misinterpretation, because again fixed HbA1c targets are applied rigidly without individualization. Again now things are changing, the guidelines are changing, and patient and family expects the HbA1c to be always less than 7. So how to overcome? Reframe the clinical goal. Use structured shared decision making. Involve the patient and the caretaker also in the decision making. Educate patient on the new goal, and also do the hypoglycemic auditing. It is very important. And probably in the future, we'll have more algorithm-based de-intensification, CGM-driven protocols, and maybe we can get lot of studies, RCTs involving the older patients. So we'll have more, whatever the evidence gap is there, that will be filled. AA-guided therapy optimization based on the CGM, frailty score, medication list, and renal function. AA tells us what de-intensification required. And our EHR also, we can integrate the de-intensification protocol. It can give us the alarm. So key takeaway, de-intensification is high-value diabetes care. It's not we are omitting the diabetes care. It prevents harm, improves quality of life, requires structured assessment, must be individualized. So in the older patient, it is we have to give best quality of life with least harm. So de-intensification done well achieves both. So I conclude my talk with wordings, do less but do it better. Thank you.